assembled on second day of ASICON 25. On behalf of Dr. Sajjan and myself, we chairpersons are happy to express our gratitude to the organizing committee for permitting us to start this session today. We have all the three presenters with us today, so we'll start the sessions one by one. I hope by the time they are on the podium, we'll have a bigger audience to join us. And keeping in time, we'll start with the presentation. I hand over my mic to.
So, Dr. Kedar Mehta. So, his topic, coverage of isolated preventive therapy, IPT among people living with HIV, registered at ART Center in a public health facility of Central Gujarat, India. Please start.
Yeah. So good morning everyone, respected judges, chairperson and all delegates. I am Dr. Kedar Mehta and would like to present my paper titled Coverage of Isoniazid Preventive Therapy among people living with HIV, registered at ART Center in a public health facility of Central Gujarat, India. It's a mixed method study. So we all are aware of the background that tuberculosis remains the most common opportunistic infections among PLHIV in India. And isoniazid preventive therapy has been proven public health intervention to reduce TB incidence among PLHIV. WHO has already recommended 6 months IPT regime for TB prevention. And based on these recommendations by WHO, NACO started to implement this IPT therapy among PLHIV to prevent the incidence of tuberculosis in 2016. And in the state of Gujarat, the implementation of IPT among PLHIV was initiated from the year 2017. But there have been no Indian studies who have recorded the coverage of IPT among PLHIV specifically in Western India. So based on this background, the objectives of my study were, number one, to determine the coverage of IPT among PLHIV. Second was to assess the factors associated with the coverage of IPT. And third was to explore the barriers to IPT from PLHIV perspective. So coming to the methodology, basically this was an explanatory mixed method study where the quantitative study was followed by qualitative. It was conducted at ART Center at GMERS Gotri Hospital based in Gujarat, Vadodara, among all PLHIV who attended this particular ART center during the year from 4 years period, that is from 2021 to 24, after getting ethics committee approval from Institutional Human Ethics Committee of our institute. Coming to the data management for the quantitative study component, the data was collected from all the records of PLHIV during this study duration from 2021 to 2024. The anonymous data entry was done in Microsoft Excel and was analyzed using Epidata software. Whereas for the qualitative, we had interviews using interview guide and 13 in-depth interviews were conducted with PLHIV and 2 key informant interviews were conducted with program managers. And transcripts were prepared and based on that, manual content analysis was done for the qualitative component. So coming to the results, if you can see the flow chart, total number of PLHIV registered were at 1790, that is 1790, out of which 1332 were eligible for IPT, whereas 387 were not eligible, either they were having coughs or TB or they had 4 symptoms screen positive, so they were not eligible for IPT. Coming to those who were eligible for IPT, that is 1332, almost 43% did not receive IPT, whereas 56.9, that is 57% received IPT. Amongst them, 625 completed the due course of IPT, that is 82%. Regularly still they are on IPT, that's 123, and 11 stopped IPT. So if you see overall, the coverage was around 57% of IPT among PLHIV. If you look at the baseline characteristics variable of all those eligible PLHIV on IPT, the mean age was around 36 years, and you can see males were 58%, 41% were female, majority of them were literate, 76%, Majority were employed, 62%, and it was almost 57% were from urban and 42% were residing in rural areas. So when we try to do bioaggregate analysis to compare the IPT coverage, that is received and not received IPT, along with the socio-demographic variables, there was no significant association between gender and IPT association, receipt of IPT. Whereas in age group, it was seen that almost 25 to 50 years of age group, the IPT coverage was higher. And in education, of course, those who were literate, once again, the IPT coverage was higher among those who were literate. There was no association between occupation and IPT coverage, whereas in residential component, if we see that those coming from urban areas, IPT receipt was higher as compared to rural areas. Coming to the manual content analysis results for the qualitative data, if we see the barriers to IPT coverage among PLHIV, broadly there were 4 themes. One was the pill burden, the second was non-compliance to IPT, the third was inadequate knowledge of IPT, and the fourth was side effects. Few quotes from PLHIV perspective was that I was well, but when I started taking this medicine, I developed skin rash, headache, weakness, so I stopped these drugs. Second was inadequate knowledge about IPT. I am fine and I don't have tuberculosis, then why should I take these TB drugs? Another was regarding pill burden. I am already taking many medicines for diabetes, blood pressure, again for HIV, that is ART. How many more medicines to take? And for non-compliance, if we see, I have been taking my HIV medicines regularly, but I forget taking this. So if you see overall qualitative component also shows that there are many barriers to IPT coverage among PLHIV, like the side effects, extra pill burden, their non-compliance to IPT because of 6 months duration, and inadequate knowledge about IPT among PLHIV. So based on this, the conclusions are the IPT coverage was 57% among PLHIV at this particular center. Socio-demographic factors like PLHIV in the age group of 25 to 50 years, their literacy status, and urban residents were found to be significantly associated with better IPT coverage. And from the qualitative findings, we can say that if proper counseling about IPT, its side effects, and if compliance is explained to PLHIV better, then they can be considered to scale up for improving IPT coverage among PLHIV. So, thank you for your kind attention.
Very excellent presentation in given time. Any questions, please? One or two questions.
It was an excellent presentation. I was thinking this is a great study to take to the higher up, to really push for rifampicin.
Yes.
Because as you show in a quantitative survey, once rifampicin becomes available, it literally takes care of 3 of those things.
Exactly.
The second thing was we give IPT once. IPT should be repeated every 2 to 3 years. So the eligible population of IPT will actually increase if you were to take into consideration that it has been 2 or 3 years since they last received.
So thank you so much, ma'am, for this point. I do agree with the point that nowadays the regime has changed to rifampicin and it is only 1 month duration, so definitely the coverage may improve, and that has been implemented from August 2024 in Gujarat, and we have started now in 2024, but this was regarding the only IPT coverage. But now rifampicin dose has been come with isoniazid, in which in Vadodara, ma'am, it has been there has been a pilot districts have been assigned, and Vadodara is one of the districts in which rifampicin has been started. So as you rightly agree, that may improve the IPT coverage. Thank you. Yes, sir. In southern India, sir, there has been one study which has been conducted in which there was a 71% coverage was there, sir, of IPT.
Can I just ask, in non-HIV, chemoprophylaxis, HIV related?
Yeah, so ma'am, now TPT has been made one of the, under NTP, TB preventive therapy has been made to all the contacts of TB positive. That those who have pulmonary coughs, then it has to be given for the coverage, TPT has to be given even to the contacts and even to the immunocompromised patients who have on chemotherapy drugs and all, it has been started. But that has been very recently, ma'am. Since 2024 they have been started, so I don't have any data related to that particular group. Thank you. Thank you, sir. Thank you.
May I now invite from the AS, Priya.
Pleasant morning all. So I'm Kamakshi Shriya. I'm a pharmacy intern at JSSCP. So today I will be presenting on prevalence, risk factors and clinical outcomes among the immune discordant patients. So this was a retrospective case control study. So I disclose that I do not have any conflicts of interest, and this would be my outline for today's presentation. So basically, coming to the heart rate.
Sorry, can you adjust that projection, please?
Patients who are receiving heart regimen can be divided into 4 categories based on their type of response. So the first category is the concordant responders, in which we can see that the patients will achieve both immune recovery and at the same time they'll achieve viral suppression. So, and the complete opposite is the discordant group, which they don't achieve neither of them. So between these two extreme groups, we do have two groups, that is immune discordant group and the virological discordant group. So the immune discordant group are the ones who do not achieve a immune recovery, but they achieve a viral suppression. So there are like multiple definitions available around the globe. So however, we chose this definition, that is the patients whose CD4 cell count is below 350 cells per millimeter cube, and there's less than 100 cells per millimeter cube raise, where we do not see that raise in the CD4 cell count. So they're considered to be immune discordant patients, and so this was conducted like for a 12 months of period. Like we have followed up the patients for a period of 12 months. So as there is a very limited data available in southern part of India about the immune discordant, so our study helps us to narrow down this gap between like by analyzing the prevalence, clinical outcomes and the risk factors among this category of patients. So the methodology. So this was a retrospective case control study, and this was conducted between the period 2016 and 2023. So all the patients registered at ASICON hospital between this period were included in the study based on the study criteria. So the immune discordant subjects not having viral load and CD4 cell count tested at the baseline and biannually within 30 days of each other were excluded from the study. So total sample size was 1,249. And these were the different tools used in the study, like individual patient files, TCS, BD-Fax Presto instrument, and Cepheid expert. So the study flow. So 1,274 patients were enrolled in the study site, out of which 96 were found to be immune discordant. So 4 were lost on follow-up and 2 were lost on transfer out, and the baseline viral load was not, the data of that was not found in 15 patients. So it was like, so we had like around 71 patients who were found immune discordant, and these patients were further divided based on the clinical outcomes. So they were like, we found clinical outcomes such as non-communicable diseases, opportunistic infections, and mortality. And 5.6% of the patients were found to be immune discordant. So coming to the characteristics, we analyzed various characteristics like gender, age, HIV transmission group, baseline CD4 cell count, presence of TB infection, and the heart regimen which they are using. So we have employed a univariate logistic regression analysis for analyzing the influence of an individual character on immune disorders, and multivariate regression analysis to analyze the individual characters in presence of the other characteristics also which can influence immune disorders. So, and we have obtained the crude odds ratio and the adjusted odds ratio with their corresponding 95% confidence interval. So here, as we can rightly see, heterosexual method of transmission had like 2.69 times higher the rate of developing immune disorders. So the other two risk factors which were found are the patients who had less baseline CD4 cell count and the presence of TB infection. So as we can see here, the crude odds ratio was 0.387 and 0.481. So this infers that the patients with the baseline CD4 cell count less than 200 cells per millimeter cube had 61.3% higher chances of developing immune disorders, and the patients with TB at baseline had 51.9% higher chances of developing immune disorders. So after a median follow-up of 52 months, we could see a lot of patients developing NCDs, like 22.53% of the immune discordant patients developed non-communicable diseases, out of which hypertension was the highest. And we could observe mortality in 8.45% of the immune discordant patients. So this is a pictographical representation of all the clinical outcomes. So here, as we can see, we had the patients had developed diabetes, stroke, and among opportunistic infections, we had cryptococcuses, tuberculosis, and mortality. So coming to the discussion, so 32.3% of the immune discordant patients had low baseline CD4 cell count. Similar observations were made by other studies, like one done by Colin. So in his study, he had 44% of DIR patients with less than 100 CD4 cell count, and 25% with 100 to 200 CD4 cell count. So this could be explained by multiple factors such as low baseline CD4 cell count and impaired proliferative capacity of the bone marrow and altered cytokine expression. So this altered cytokine expression can lead to apoptosis. And in our study, we could observe that co-infections also influence the results of the immune discordance. And there were other studies done by Dr. Hailu, and so they could also explain this. Like they had TB and HPV co-infections observed, and the possible mechanism behind this would be because infections exaggerate pyroptosis and T-cell activation, which would ultimately lead to cell apoptosis. So the mortality observed in our study was 8.45%, and this study was similarly, the similar work was done by Frederick, and he could observe 20% of mortality among the immune discordant subjects. So there was a surge in the inflammatory markers, cytokines and adhesion molecules among the immune discordant subjects, which could have led to altered arterial vasomotor response and carotid endothelial thickening, so which could ultimately lead to the death of the patient. So I would like to thank everyone who have helped me complete this study. And early diagnosis can prevent the ramifications of the chronic diseases, which could be prevented if we had diagnosed it earlier. So thank you. Any questions from the floor?
Yeah, the session is open for discussion, for comments. Dr.
Thank you. Very nice, good idea and very nice presentation. Very good. I didn't know, maybe it was a little too fast for me, but have you included nutrition? I didn't see any weight changes. But nutrition is also another important factor for improving the immune function. And I understand active TB,
Yes.
but active TB is only for 6 months, huh? 8 months. So once TB is cured, would the discordance improve or better?
So basically in our study we were looking for baseline TB. So people who had baseline TB were included in this study. So those people with all these co-infections, like not only TB, any other co-infection also will influence the immune discordance by exaggerating the T cell response and pyroptosis, because the presence of an infection can lead to pyroptosis. So that would have influenced the immune discordance.
Yeah, apart from TB and hypertension, did you observe any other opportunistic infections in this way?
Yes, sir. We observed cryptococcuses also, and among the NCDs we observed diabetes, stroke.
No, I'm speaking about OIs.
Yeah, opportunistic infections we observed TB and cryptococcuses in our study.
If it is a significant clinical problem, you should have had more OIs being present in this type of meetings.
So like we had multiple things like histoplasmosis also, but then the thing was we included I have represented only like TB because it was significantly shown in our study, like the baseline.
One of the recommendations that you gave was that if you diagnose early, it's going to make a change.
Yeah.
So what are you going to do if you make a diagnosis early?
So sir, there's a trial, like phase 3 trial, Motivate trial, which is going on Maravirog. It's a CCR5 inhibitor, which has a potential to increase the CD4 cell count at 48 weeks. So if a patient is recommended with that drug, so there are chances that patient might come out of this immune discordance. He might have a good immune recovery. So that's being under trials right now. So that can be one of the potential use.
Thank you. For the benefit of the audience, can I ask one of the audience to clarify on this issue, that if we diagnose discordance at a very early stage, is there anything that we have to do specifically? Dr. Dilip? To diagnose discordance early and you have a patient who hasn't developed any OI or NCD, can we do something to prevent something? Apart from an observation, does it act as a point of intervention? It's a beautiful observation.
Thank you so much, sir.
Point that you have brought into the notice of the science.
Yes.
Thank you.
Thank you so much.
Next speaker, Dr. Nataraj Shetty HS, cardiac manifestations in people living with HIV and its management Indian registry.
Good morning, respected chairperson and my dear friends. Today I am presenting a paper on cardiac manifestation. This paper is a little bit away from what we are discussing, like microbiology, pharmacology, pathology, community medicine. We are playing with emergency medicine, emergency cardiology. What are the HIV patients present in the emergency department, like intensive care unit, coronary care unit? It's an honor to present a paper in this National AIDS Conference. Thank you very much for the organizing committee. Come to the introduction. The leading cause of death in India is now cardiovascular disease. 25% of all deaths are attributable to CVD. There are limited comprehensive data and temporal trends in CVD risk variables and outcomes in HIV positive individuals. This population-based study, which lasted from February 2013 to 2024, aimed to determine the prevalence of key cardiovascular disease risk factors over the last decade, determining the innovative diagnostic and therapeutic target, as well as potentially influencing CVD risk assessment for HIV positive individuals. Depends crucial on refinement of HIV-specific factors to CVD pathophysiology and interventional procedures, including percutaneous coronary interventions, primary PCI, rescue PCI, single vessel disease, double vessel disease, and triple vessel disease, left main bifurcation, chronic total occlusion, and percutaneous transvenous mitral commisuratum, that's PTMC. Coming to the methodology, in a prospective cohort study, we assessed the cardiovascular manifestation, clinical and angiographic profile of 768 male and 142 female HIV positive individuals from both urban and rural regions of the Karnataka in India and neighboring states. To describe the prevalence of CVD risk factors, we conducted thorough literature search for an embassy and PubMed databases. The study included retroviral positive patients present with acute coronary syndrome and treated with a drug-eluting stent for a de novo coronary lesion with significant size disparity between reference segments. The primary endpoint of the study was cumulative incidence of major adverse cardiovascular events composed of cardiac death, myocardial infarction, clinically driven target lesion revascularization, and follow-up. Come to the results. Before enrollment of 9-10 patients, 86.2% were male, and among median age of 50, that internal quarter lesion 59, and 13% were female with median age of 50. The most patients present with acute anterior volume, that is ST segment elevation myocardial infarction. 873 patients received thrombolytic therapy with a streptokinase, tenecteplase, urokinase. These are the life-saving medications. Thrombolysis successful, but 95% of thrombolysis very successful, and 4.6 patients were failed. 28 underwent rescue angioplasty, that is failed thrombolysis, and 16 underwent primary percutaneous intervention. That's primary percutaneous intervention means whenever the patient presents with intensive care chest pain of HIV individual, we direct immediate shift to the catheterization laboratory, doing immediate angioplasty is a life-saving procedure. The coronary angio were done all the patients revealing significant residual stenosis of 545 patients. 380 patients had significant single vessel disease, 160 patients double vessel disease, 49 patients significant triple vessel disease. All patients with significant residual lesions underwent PCI with the drug-eluting stent. 25 patients died due to cardiogenic shock, and remaining 850 were followed for 5 years. They were received adjuvant antiretroviral therapy with adjuvant dual antiplatelets. In our study, the majority is, that is 30 to 40, 12% of younger population, between 4th and 5th decades 39%, between 5th and 6th decades 32%. Patients known HIV, that is known are 756, that is 83%. Newly detected on table during evaluation is 17%. Gender population, male is 86%, female is 13%. Failed, that is thrombolysis, successful is 95%, failed is 4.9%. Other comorbid assessment, we assess for HIV individual like diabetes, hypertension, COPD, chronic kidney diseases, drug abusers, and other dyslipidemia. The primary PGSA, that's 2.9% went to primary angioplasty. That is, what are the failed thrombolysis went to rescue angioplasty 5.10%, and elective seizures 866. All patients underwent single vessel disease 380, double vessel disease 116, triple vessel disease 49. We evaluated the CD4 count. Between 200 to 400 is 51%, more than 400 is 47%. Among majority patients we are discharged with regular follow-up. Death rate is 25 to 2.8%. Where there is a non-compliance of the medication due to the cardiogenic shock or maybe re-MI, re-infarctions. Following these parameters are difficult to assess. Coming to the conclusion of the study, the risk of coronary artery disease is high in people with HIV and is observed to occur much earlier when compared to general population. The presence of other traditional cardiovascular in this population is less, and the disease appears more diffuse, severe than in the general population. Anterior is most common presentation, LAD is the most culprit vessel. PCI is the effective treatment strategy for coronary revascularization in people living with HIV. HIV status and outcome did not enter with the revascular approach or clinical outcome. People living with HIV with ACS are relatively younger. Presentation or outcome of ACS in this population is similar to those with general unaffected patient. This is one of the Indian registered C2 people living with HIV navigating complex intervention. Whenever the patient with HIV patient, they will present in 6 months, later 1 year, they will have a chronic total occlusion, that is RCA. This is a very, very challenging case. It requires extra hardware, extra manipulation, and operator technique is very, very, very important. This right side coronary artery is total. You open it with special hardware, the right coronary becomes T3 flow. If we perform about 25 patients. Second one is percutaneous device closure in atrial septal defect. Whenever there is congenital heart defect with atrial septal, we have a device implantation, we can avoid the surgery, then improving the mortality, improving the morbidity of the and quality of the life is also improved. Coming to the navigating challenges of PTMs in people with HIV, severe mitral stenosis. Whenever this HIV positive presents severe mitral stenosis in the ICU, there is sudden acute pulmonary edema. When there is acute pulmonary, there is a left atrial pressure increase, pulmonary venous pressure increase. When do balloon pulmonary PTMC, we can save the life. This is very, very important technique. About 13 PLWHO done PTMC with the ballooning technique. This is also advanced technique. Rotablation is in the treatment of high-risk patients with heavily calcified lesion, like association of comorbidities like diabetes, hypertension. We use the rotablation. Rotablation is a very, very different hardware. It has a diamond chip with the microplates. If you do the diamond chip the right level, you can break out the calcification. Then you can improve the coronary circulation with the stent implantation. You can see the OCT showing before and after. See the heavy calcified lesion. Another topic is most important, left main coronary intervention. When there is a left main coronary intervention, CABG, that's called CABG, the CTVS department, surgical department is sometimes reluctant to take the case. When there is a corruptible disease, then the family members also not giving consent. Then our cardiology role will come. Doing a left main bifurcation with a double stent strategy, then the patient quality of the life improve. It is equal to the CABG. We have done about 10 to 15 patients of left main bifurcation. And feasibility outcomes of PCF novel tapered coronary. This is also advanced technique. When you have a double vessel disease, long segment lesion, you have put a drug in stent implantation, long coronary lesion, we can treat restenosis. In working with ICU, there is a cardiac tamponade. In people with HIV, there is cardiac tamponade. There is accumulation of the water in the cardiac. This 1.5 to 2 liters. Patient is having hypertension, it requires emergency pericardiocentesis. Do emergency pericardiocentesis, we can save the life. And association, maybe we have to roll out associated tuberculosis and opportunity. We have done about 15 patients of cardiac tamponade in HIV. And this is usually seen in thrombus aspiration in people living with HIV. Thrombus aspiration, whether it's myocardial infarction in young individual like 25-30 years, some drug abuse, difficult to manage the drugs. You have an export catheter to aspirate the thrombus, you can save the life. So before treating as a clinician, as a physician, as a cardiologist, you should have a goal, you should have a vision. What is our vision? What is our goal? Paving the way for AIDS-free India, our mission is attaining universal coverage of human immunodeficiency prevention, treatment care, continuous services that are effective, inclusive, equitable, and adapted to needs. Our goal is to 3 zeros, 0 new infections, 0 AIDS-related deaths, and 0 discrimination. We are working with this goal. Whenever the patient with coronary care and intensively with retrovirus positive patient, we have to prevent the death and decrease the mortality rate and improve the quality of the life. Morbidity will be come down.
Thank you, Dr. Andraj Reddy. This session is open for comments.
This is about almost 1,000 patients have completed for the past 15 years. Whatever the patient we are working with the Day-2 Institute of Cardiology is a government setup. What you have done, all these proceed with the novel technique, with innovative technique, with imaging, with free of cost. All the patients.
Sorry, I just beg to differ. The premise of this study, you said that it was a prospective cohort of patients that you reviewed or that you analyzed. I see it as a retrospective collection of data. So the whole premise of the study that you're presenting is wrong. Okay? So that's all I beg to differ with many of the conclusions that you have made, and that's for later. I just wanted to say that the premise of the study that you started off with is incorrect. Okay, thank you very much for your presentation.
Yes, thank you.
Congratulations, Dr. Shetty. You have done for over 1,000 patients, 910 patients over 10 years, almost 100 per year. Excellent work. I don't know if there is any center in the world that has done so many coronary angiograms and angioplasty. Very good, excellent. I congratulate you on your work. Only one doubt I had was, I didn't see any patient post-PCI requiring or needing open coronary artery bypass surgery.
No one has.
No one.
No one has.
No single.
No one has.
Brilliant.
This paper I have presented American College of Cardiology, Washington DC, and European AIDS Clinical Poland and Washington. Last 3 months back, this thrombus aspiration young population presented in European Clinical Society. This is one of the biggest cardiac center in London. I have presented this paper. They were going to give best award for this paper.
Thank you, Dr. Shetty, for that presentation. I hope Dr. Jyoti has suggested some of the conclusions needs to be verified and some of the
This
conclusions.
is an ongoing study.
Yeah,
They are
they
not
have to be
completed. It is an
justified.
ongoing study.
Some of them have to be justified. Like for example, the age of the patients.
Because no literature, the most important drawback is there is no literatures are available
No, when-
and regular follow-up, all those things. It's an
When
ongoing
we say
study.
some of those
Definitely.
things are directly related to
Sorry.
Where it's a
I don't think we need discussion on this paper. The thing is that you can only draw conclusions if you were comparing like with like. There are no comparisons, okay? There's no comparator arm to this. So drawing conclusions are erroneous. That's all I'm saying. I'm not, questioning the validity of the work. I'm not questioning. I'm just talking about the presentation. I'm not talking about, the work that's been done. I'm not questioning that. But what I'm saying is you cannot draw conclusions when you have nothing to control. You don't have a control arm. So presenting it as a prospective data is also incorrect. That's what I'm saying. It's a retrospective cohort of nearly 910 patients that have been analyzed and presented today. That's all I'm saying. I'm not talking about the validity of your work. I'm not discussing that. But I'm talking about the presentation. All right?
It's an ongoing project. Still.
Thank you very much.
Thank you. Good correction. I think that brings us to the end of this particular session of oral presentations as the first session of the second day. Thank you once again to the organizers.
Thank you very much. The nice presentations of 3 speakers. And thank you very much for giving the opportunity to chair this session. Thank you.
Thank you very much. I request Dr. Sajithkumar to kindly hand over a token of appreciation to Dr. Sajjan. Thank you. With that, we move on to our next session of the day, ART Revolutionizing the Fight Against HIV, MCure session. For this session, I would like to call upon our chairs, Dr. Vipul Shah and Dr. Mahesh Soli. Thank you, sir. I hand over the proceedings.
Very good morning and very warm welcome to the ATCD Ahmedabad. In this session of session number 7, the antiretroviral therapy, revolutionizing the fight against HIV. As we know, there are few infections in HIV patients where there is no specific therapy or no specific antiviral therapy. One of them is JC viral infection, which leads to progressive multiple leukoencephalopathy. To talk on this, the clinical innovations and role of specific T-cell therapy, we have our own first speaker, Dr. Joan Schneider from Germany.
ASICON welcomes Professor Dr. Joachim Schneider. Dr. Schneider is a professor at Technical University of Munich, Germany. He is a senior consultant specializing in infectious diseases. Dr. Schneider has experience as both a sub-investigator and principal investigator in numerous clinical trials. His board examinations and specializations focus on microbiology, virology, and epidemiology of infectious diseases, as well as internal medicine and infectious diseases. He has received grants for research from organizations like the German Research Foundation, DFG. We look forward to hear him talk on PML, clinical innovations, and role of JC-specific T-cell therapy.
Wow, thank you for this nice introduction. Actually, this is my first time here in India, and I'm really happy to be here. And I'm really grateful to Dr. Ilara and to the chairs for inviting me to the talk. So, let us begin. So, concerning my upcoming talk, I have no conflicts of interest. So, let's go over some key epidemiological facts concerning PML. PML is a rare, severe opportunistic disease that is caused by the reactivation of the JC virus in, of course, severely immune-compromised hosts. The JC virus is usually acquired in the childhood, and this virus infects round about 50 to 80% of the global population asymptomatically. While HIV had been the driving cause of PML in the past, like in the 80s or in the 90s, the epidemiology of PML has changed in the last 20 years, with an increasing numbers of patients receiving immunomodulatory therapies for example, autoimmune disease or for hematological disease. And one reason for this epidemiological shift, of course, has to do with the introduction of HAART in the mid-90s that resulted in a significant decline in the incidence of PML in people living with HIV. So now let us focus on the long-term outcome of PML. And now I want to involve you, the audience, by asking you two questions. So what do you think? What is the estimated 10-year survival rate for people living with HIV who are on RNT and who have been diagnosed with PML? Is it A, lower than 10%? Please raise your hands. Okay. Is it B, 20%? Please raise your hands. Is it 40%? Please raise your hands. Is it 60%? Okay. And who thinks is 80%? Okay. Before I give you the answer to that question, I want to continue with question 2. So what do you think? What is the underlying condition? Which underlying condition is linked to the most favorable long-term outcome in patients suffering from PML? Is it A, chronic inflammatory disease? Please raise your hands. Or is it B, HIV? Okay. Or is it C, hematological malignancy? Or it's a solid tumor disease? Or do you think that there is no difference in the outcome concerning the underlying condition of PML? Okay. So, here are the answers. First, PML is the outcome of PML is highly dependent on the underlying cause. Patients that do have chronic inflammatory diseases have the best prognostic outcome in PML, followed by patients living with HIV. And the worst prognostic outcome do patients have suffering from an hemato-oncological disease. On the right side, you see the long-term outcome in HIV-associated PML in the post-hoc area. So, round about 22 patients or persons living with HIV and who are suffering from PML are still alive 10 years after their initial diagnosis of PML. Diagnosing PML mainly relies on imaging findings and on analysis of the CSF. Whereas clinical symptoms are not that specific. They range from speech disorders over behavioral disorders to sensomotorical disorders. Below you can see the typical imaging findings of a patient suffering from PML. On the right, you see the MRI flare imaging with subcortical signal intense lesions. And on T1 weighted imaging, you can see hyperintense lesions, and on T2 weighted imaging, you can see once again hyperintense lesions sparing the cortex. And these typical imaging patterns in combination with positive PCR for the GC virus from the cerebral fluid help to establish the diagnosis of PML. So let's talk about current treatment concepts in PML. So the major strategy in the treatment of PML is, of course, to achieve immune reconstitution as soon as possible. As we all know, that a fast immune reconstitution is associated with a better outcome. And immune reconstitution can either be achieved by initiation of RT in people living with HIV or by discontinuation of immune suppressive drugs. For immune stimulation, checkpoint inhibitors like pembrolizumab can be used to activate CD8 T cells against the virus, against the GC virus. Antivirals include cidofovir, leflunomide, or mefloquine, but none of these antiviral drugs have proven their efficacy against the GC virus and therefore are not recommended by the international guidelines. And in emergent treatment approach on the right side, you see virus-specific T cell therapy. And this includes the infusion of virus-specific T cells to enhance the immunity against the virus. But please keep in mind, PML is a really, really rare disease, and therefore conducting large-scale clinical trials is really, really challenging. And that's why currently there is no clear evidence for the emerging treatment concepts in PML, like pembrolizumab or virus-specific T cells. This evidence is still missing or lacking. So, pembrolizumab. How does this work against the GC virus? The GC virus can suppress our immune system, similar to how a tumor can evade immunity. And by blocking the PD-1 pathway, the CD8 cells are activated against the GC virus and therefore can targeting this GC virus and hopefully result in virological clearance of the GC virus. Pembrolizumab is a promising but yet experimental approach to treat PML. Clinical experience is unfortunately restricted only to case series, so no randomized controlled trial exists up to date. But putting all these case series together or analyzing them together, it seems that pembrolizumab might achieve clinical improvement in round about 50% of patients. But please keep in mind that when you're using pembrolizumab, the use of pembrolizumab also includes side effects like immune reconstitution syndrome, which of course can worsen PML symptoms, and of course immune-related adverse events like pneumonitis, hypophysitis, or hepatitis. So let us come now to the major focus of my talk, virus-specific T cell therapy. How does this work for PML? Virus-specific T cells can be manufactured in two different ways. Either, for example, here in the red box, by in vitro expansion of virus-specific T cells in the lab. But this approach takes, it's really, really time-consuming because it takes several weeks to expand these T cells to a sufficient number of T cells that you can use then for PML treatment. And once again, time is a crucial factor for PML treatment, as we all know that fast immune reconstitution is essential for a good outcome. Another on an alternative approach here in the green box is so-called directly isolated allogeneic virus-specific T-cell therapy, or short-term dialysis. This is a much more faster, ready-to-use approach that provides pre-isolated virus-specific T-cells within 24 hours by isolating or collecting them directly from the patient's blood. Please do not mix up virus-specific T-cell therapy with CAR T-cell therapy. Virus-specific T-cells are non-manipulated lymphocytes from a third-party donor, whereas CAR T-cells are the patient's own lymphocytes that are genetically manipulated and reinfused in the patients. So what are the potential adverse events of virus-specific T-cell therapy? This includes graft-versus-host disease and infusion reaction. So, this study was published last October in JAMA, and this study evaluates directly isolated allogeneic virus-specific T cells in PML. This study was a retrospective single-center analysis including 28 patients receiving virus-specific T cell therapy. Virus-specific T cells were administered up to 3 times a day in their patients. So what were the primary outcomes of this study? There were 2 primary outcomes. First, the clinical response rate measured by the ranking score scale. You see the ranking score scale on the left side. The ranking score scale is a standardized measure of neurology disability ranging from 0 to 6 with a higher score indicating a higher degree of disability. And the second primary outcome measure was the 12-month survival rate of a patient receiving virus-specific T cells compared to a historical PML cohort that did not receive virus-specific T cells. So what were the major findings of that study? First, virus-specific T cell therapy was well tolerated. So no graft versus host disease, no iris were observed. And virus-specific T cell therapy results in a clinical stabilization or improvement according to the ranking score scale in round about 80% of patients. And third, patients who received virus-specific T cell therapy showed a significant higher 12-month survival compared to the control group. So 69% versus 50%. So let us discuss now a real patient case. This is a 22-year-old patient presenting with an HIV-associated PML after developing a left-sided hemiparesis. At the time of initial diagnosis, the patient already showed severe signs of neurological disability. So he had a modified ranking score of 5. His CD4 count was 4, and the viral load, the GC viral load in the CSF was 3.6 millions per milliliter. Apart from his PML, pulmonary Kaposi sarcoma was diagnosed in that patient. So we put him on RT and initiated liposomal doxorubicin for Kaposi treatment. And so my question to you is, what would you do in this case for specific PML treatment? Would you choose pembrolizumab or virus-specific T-cell therapy? Just think about it. I can tell you what we did. We decided against pembrolizumab for PML treatment due to his low CD4 count. pembrolizumab can only sufficiently activate or reactivate CD8 T cells in the presence of a sufficient number of CD4 cells. That's why we decided against pembrolizumab and for the use of virus-specific T cell therapy. Unfortunately, approval for reimbursement for the virus-specific T cell therapy in that patients has taken more than 10 weeks for approval after the initial diagnosis of PML. And once again, time, you can see here, time is a crucial factor in PML. Because by that time, we could observe that the JC virus load increased significantly from 3.6 million copies to 42 million copies. So we started him on virus-specific T cell therapy. And after the second dose of virus-specific T cells, was after after the first doses of virus-specific T cells, we could observe a significant decrease of the GC virus load in the CSF from 42 million copies to 4.6 million copies. But unfortunately, we did not see any clinical neurological improvement. Still had the patient modified ranking score of 5. And sadly, sorry for that. And sadly, before we could give him the third dose of virus-specific T cell therapy, the patient died due to severe CAPRISA-associated lung failure. So, what are my take-home messages? First, the epidemiology of PML has changed. In the past, PML was mainly caused by HIV. Now it appears more and more in patients receiving immunomodulatory therapies for autoimmune disease or hemato-oncologic disease. Second, the outcome of PML significantly dependent or highly dependent on the underlying disease or the underlying condition. And third, mainstay or in HIV-associated PMA, mainstay therapy of is still to initiate RT in order to achieve immune reconstitution as soon as possible. But emerging therapy approaches like pembrolizumab or the GC virus-specific T cell therapy are promising upcoming therapeutic approaches for the future treatment of PML. So thank you for your
Thank you, sir. Lucid presentation regarding PML. Any question answer we will discuss after the completion of the 3 sessions. So we are inviting the new speaker. If you
After the session. We have a cohort of more than 50 PML patients, and we have seen the survival of PML as against we have 1 in 5 beyond 10 years, we have 4 in 5 for beyond 10 years, maybe 20 years, 25 years. Yeah. One of the best drugs for PML was indinavir. As soon as indinavir was withdrawn from the market, some of our patients progress. And currently, one of the best drugs to penetrate CNS is azathioprine, AZT or zidovudine. So we have to just plan the drugs which will penetrate CNS. The moment you, because of hemoglobin or something, you remove zidovudine, they progress. And once they survive with some handicap, that like stammering speech or heavy paresis or something, stamping gait, they survive with some handicap. But they are surviving fantastically, 25 years. I have my oldest PML patient is around 26 years diagnosis.
So maybe you see much more PML associated in Europe. Maybe you see much more HIV-associated PML in India than we do. But I've only I've seen 10 patients with PML, and 8 of 10 patients died, either due to PML-associated complication or due to other opportunistic disease. So that's my experience, but maybe this might be here different.
And we have not done any other treatment than ART. No other treatment PML, except ART.
Okay.
We have treated only with ART.
Yeah, we are treating only with ART and no other drugs. No. Okay.
Any question? Thank you, sir. So, we are in the era of HIV. It's a patient's right to have a choice of the drug. Sometimes patient tired with oral pills like that. So our scientists also working in that direction also. And injectable ART in adolescents is a somewhat new, you can say new way of the treatment. And for that I am inviting Glory Alexander on the stage. Thank you.
ASICON welcomes Dr. Glory Alexander. Dr. Glory Alexander is the director of ASHA Foundation, Bengaluru. A seasoned consultant in the field of HIV/AIDS, Dr. Alexander is Vice President of the AIDS Society of India and is a governing council member. She is a member of the International AIDS Society, an honorary member of GAPIO, and a temporary advisor to the WHO, demonstrating her international standing. Dr. Alexander has contributed to the medical literature with publications in national and international journals. Her work has been recognized with prestigious awards, including the Dr. B.C. Roy Award in the International Ashoka Fellowship. We look forward to hear her talk on injectable ART in adolescents.
Thank you. Good morning. The topic for this session is injectable ART in adolescents. The IAS had sent an update in 2024 about this, and that is why we have included this in this conference. Just to refresh our memories, what is adolescence? Very simple question. Adolescence is the transitional phase between childhood and adulthood. It's typically characterized by physical, psychological, and social changes, and begins with the onset of puberty, which could be as early as 10 years old, and extends into the late teens or early 20s, which could be up to 22 years old. During this period, as we all know, individuals undergo significant growth and development, both physically and emotionally, as they navigate issues such as identity formation, peer relationships, and autonomy. Adolescence is a critical stage in human development, shaping future behaviors, beliefs, and relationships, and often involves challenges and opportunities for personal growth and exploration. So it's a very long, tricky period, this period of adolescence. And why does that happen? That's because all parts of the brain don't mature at the same time in adolescence. The amygdala deals with emotions and matures early. The prefrontal cortex, which actually regulates behavior and decision making, it matures late. So teenagers process information with their amygdala, rather they process information with their emotions, which they may not be able to control. So during adolescence, you see these young people trying to assert their independence. They don't want parental support. They don't want to engage with healthcare services. They don't want to, they get tired, pill fatigue is there. They can stop their medication if it is out of their normal routine. If they are traveling, they can stop their medicines. If they are under tension or if they have exams, they may not take their medicines. Today, there are over 1 billion adolescents living in the world. And new HIV infections among adolescents are not decreasing as quickly as they should. In the year 2013, an adolescent between the age of 15 and 19 was newly infected with HIV every 2 minutes. Progress is also uneven across different regions. The Asia-Pacific region has 9 new HIV infections in young people every hour, and 9 young people dying from AIDS-related deaths every day. HIV infections are increasing in low and middle income countries, and especially in young key populations like Bangladesh, Afghanistan, the Philippines, etc. In many countries like Indonesia, Thailand, Myanmar, Cambodia, almost 50% of new infections are in young people in the age group of 15 to 24 years. Now, with the advent of simplified combination ART, with fewer side effects, only once a day dosing, there is increased longevity in adults and children living in HIV, but surprisingly, or rather not surprisingly, among adolescents living with HIV globally. In 2015, UNAIDS reported that HIV/AIDS was the leading cause of death among adolescents in Africa, and it continues to remain a killer in this age group. So if you look at Africa, this is from the UNAIDS statistics in 2023, about 3,600 new infections occurred in adults and children every day, and 50% of them are in sub-Saharan Africa. About 320 are among children under 15 years of age, and about 3,200 are among adults aged 15 years and older, of whom almost 44% are women. About 30% are among young people, and about 17% are among young women in the age group of 15 to 24 years. So this is a significant problem. So what are the challenges that adolescents face? Although adherence to antiretroviral therapy is paramount for treatment success, the need to swallow daily pills, even if it's just one single pill a day, can be a challenge for some adolescents. Most reasons for lack of treatment involve difficulties in taking daily oral ART, and as I said before, pill fatigue, change in daily routine, travel, societal barriers, dislike to engage with healthcare services, etc., can all contribute to them being irregular with their medicines. This is also the time that youngsters may be struggling with their gender identity or their sexual preferences and may indulge in risky behavior, further contributing to the problem. So what are the possible solutions? One solution is to reformulate chronic medication in a longer acting, more discrete form that requires less frequent dosing. For example, we know that we can give long-acting reversible contraceptive options which are both acceptable and result in better reproductive outcomes compared with oral medication taken daily, even in younger women. And of course, the famous preventive study among young women in Africa, where they received twice a year long-acting subcutaneous lenacapavir and found an almost 100% success in prevention of developing HIV compared to the oral PrEP. So these were some of the studies that were done about long-acting drugs, which you begin to think then could be a possibility in adolescents. For a long time now, everybody knows that long-acting injectable cabotegravir and rilpivirine have demonstrated safety, acceptability, and efficacy in adults living with HIV, and is licensed for individualized treatment of HIV infection in resource-rich settings. But what about low and middle income countries? So this was a study called the CARE study, which was done in African countries to see whether it was feasible to give long-acting drugs, long-acting HIV drugs, to people living with HIV in low and middle income countries. So CARES was a randomized, open-label, non-inferiority trial which was conducted at 8 sites in Uganda, Kenya and South Africa to study whether switching to a long-acting therapy with injections every 8 weeks is non-inferior to oral therapy. So participants with a HIV viral load below 50 copies per ml on oral antiretroviral therapy and with no history of virological failure were randomly assigned 1:1 to receive cabotegravir 600 milligrams and injection rilpivirine 900 milligrams by intramuscular injection, one injection in each gluteal muscle every 8 weeks, or whether to continue the oral therapy. The primary outcome was week 48 viral load, whether it was below 50 copies per ml or not. There were 512 participants in the study. 58% of them were female, which is a good thing. We are seeing more and more involvement of females in research, which was something that was missing for a long time in the early days of HIV research. And of these 512 participants, 380, that is 74%, had previous NNRTI exposure, keeping in mind that injection rilpivirine is an NNRTI. So the results at week 48, they found that 96% of patients, participants in the long-acting therapy group and 97% of patients in the oral therapy group had viral copies less than 50 copies per ml. So demonstrating that long-acting long-acting injectable therapy was non-inferior to oral therapy. 2 participants had virological failure in the long-acting group, both with drug resistance. None had virological failure in the oral therapy group. Adverse events of grade 3 or higher were about 9% in the long-acting injectable therapy group and 4% on oral therapy. 1 participant discontinued long-acting therapy. Long-acting therapy, therefore, the conclusion was that long-acting therapy had non-inferior efficacy compared with oral therapy with a good safety profile and can be considered for African treatment programs. So that's how the decision was that if it's good for adults, what about adolescents? Because giving them long-acting therapy where they have to take injections only once every 8 weeks is a good option for them. Injectable cabotegravir plus rilpivirine is the first long-acting combination ART approved, but data on use by adolescents are limited. And so, as some adolescents living with HIV face challenges with adherence and stigma, a long-acting regimen could have benefits. So this single-arm phase 1-2 trial reported outcome data among 144 virologically suppressed adolescents who switched to the regimen and were followed for 48 weeks. The study sites were in Botswana, South Africa, Uganda, Thailand, and the United States. The median age was 15 years, ranged between 12 to 71 years. Again, 51% were female, slight majority, and 92% had acquired HIV vertically. At week 48, 97% of participants had received all planned injections, and 97% had HIV RNA of less than 50 copies per ml with no confirmed virological failures. And in the pharmacokinetics, the trough levels were similar to those seen in the adults. There were no unexpected safety events or drug-related serious adverse events. 34% had injection site reactions, mostly grade 1, and mostly resolving within 7 days. While pain was commonly reported following injection, 100% of participants preferred the long-acting injectable regimen over oral ART. Even in our group of adolescents that we treat, when we give them a choice, so whether you would like to take oral tablets or injections, we always found a majority of them opting for injections. And if you look at this graph, you can see that there was pain, there was some swelling, there was some redness, both with injection cabotegravir as well as with injection rilpivirine. And every time they came for an injection, there was some reaction, though of course it reduced compared to the first time, but it was always there. And yet these children were willing to take that pain and that swelling and that redness, and 100% of them preferred the long-acting injectable regimen over the oral ART. Of course, what are some of the current issues? This treatment regimen has not been endorsed by WHO and thus is not yet included in treatment guidelines. Regions in low-income and middle-income countries have high rates of NNR-TI-resistant mutated virus because in these countries, efavirenz, nevirapine have been used for long periods of time. And the study was done in a small group of people, but when it is scaled up, we might find that there is some resistance, especially to rilpivirine. And this might undermine the effectiveness of both cabotegravir and rilpivirine. A two-drug regimen may not be ideal in regions where viral resistance measurement is not readily available. The injection combination requires refrigerated storage and therefore is not suitable for African settings, but this problem is not insurmountable. It happened during COVID when we could give COVID injections which also need refrigeration without too much of a problem. So conclusions, adolescence is one of life's critical transitions, and as caregivers working with young people, we need to remember this and accept that they are working with their emotions and not with mature minds, and therefore not be too harsh with them. Remember that new HIV infections among adolescents are not decreasing as quickly as they should. HIV continues to remain a killer in this group in low and middle income countries. The issue is with adherence and societal factors and emotional factors. Generally, adolescents prefer injections to oral medications. They don't have to worry about taking an oral pill daily. Injections are generally safe, except for injection site reactions. In the Lusaka Declaration in 2023, a young girl said, "With injections, we can live our life freely and not worry about having to take a pill every day, hiding from the world." So injectable ART should be another option for adolescents in the armamentarium of treatment for HIV, but should not be the only other option, because we know that they require multiple options, and all the studies which are being done about once-a-week therapy with oral drugs or injection cabotegravir with subcutaneous lenacapavir, all of these are options which should also be studied in adolescents, so that many options are available for children and adolescents. That's what MOCA stands for. The value of injectable ART in adolescents in the Indian context still needs to be assessed, and we hope that that can be done sometime in the future. Thank you for your attention.
Thank you so much, Dr. Glory, for a wonderful insight in the topics. Any questions? Okay, we will take the questions at the end of the session. Thank you so much. So now moving forward, we have Dr. Kumaraswamy. He's going to talk on the impact of ART research when where to use the newer antiretroviral drugs.
ASICON welcomes Dr. Kumaraswamy. Dr. Kumaraswamy is the Chief and Director of PHS Infectious Diseases Medical Center, Chennai. Dr. Kumaraswamy directs the Chennai Antiviral Research and Treatment Clinical Research Site, conducting trials on HIV, hepatitis, TB, COVID, and other infectious diseases. He has published over 400 manuscripts with his work on antiretroviral therapy impacting treatment programs in developing countries. Dr. Kumaraswamy serves as an expert panel member for the WHO ARV Treatment Guidelines Committee and is a clinical advisor for the Clinton Health Access Initiative. He is particularly interested in the long-term impact of antiretroviral therapy in settings with limited resources. We look forward in hearing him talk on impact of ART resistance when and where to use the newer ARV.
Thank you for the video introduction. I like to look like that, but that picture was taken many years back. So again, thank you for being here on this Saturday morning. So what I'm going to talk to you today is on the impact of antiretroviral resistance and what will be our future treatment options, when you have resistance. I've been doing this talk, this ASICON for the last 1.5 decades, talking about various resistance on P4T, 3TC, nevirapine, efavirenz. And today, I'm going to release certain blockbuster data, which has not been published, which I can, please preserve. As all of you know that, so antiretroviral therapy is lifelong, and it will work only if they take it. So this is our good patients, they keep taking this. But on the other hand, all our good patients, they're also regular living beings, like us. So we tend to forget medicines. And everyone tends to do that in all diseases. So there could be a blips like this. And there are several modeling studies have shown if you got more than 2 or 3 blips like this, it can lead to viral resistance, especially to the low genetic barrier drugs like nevirapine and efavirenz. Now you're going to see on the highest genetic barrier on Dr. what had happened to this. Again, I've shown this many times. The first thing someone fails is on virologically, next is followed by immunological and clinical. Our group and others have modeled and published areas shown that the duration between virological failure to clinical failure could be anything from 6 months to 2 years. That means if you're not doing viral load monitoring, you'll be seeing patient in your ICU, after 2 years. And also, studies have shown this drug resistance mutation can develop either along with the virological failure, even before our so-called definition of virological failure. Even when they have very low level viremia, in WHO we have 1,000 viral load copies. In other countries, much lower. So it can even develop even much before our own definition of virological failure. And also, if you continue the failed regimens, it can keep accumulate. Sometimes it can jeopardize future regimens, some of them under development. So you will hear more about the next talk on the interpretation of resistance, but I'll show a little about the principle. It develops under suboptimal drug pressure, and also the mutation can occur to RT protease and integrase genes. And once developed, they're permanently altered, not like antibiotic resistance. You can use the same drug next time when they have an episode here. Once done, that's done. Some drugs have low genetic barrier, like nevirapine and efavirenz, so that's what so a lot of mutations, and can have class resistance. Same thing, if they have resistance to dolutegravir, resistance to bictegravir, don't change. The resistance to raltegravir, the resistance to dolutegravir. Same like nevirapine and efavirenz, we never interchange, and also like between AZT and D4T in the past, and also between 3DC and FTC. And also, there are any number of studies have shown if you continue failed regimen, which can accumulate. Like NNRT we have seen, and as well as with the AZT we have seen accumulation of CAMS mutations. Now with the DTG, we have started seeing some data. And also with the protease inhibitors, if you continue the failed regimen, which can accumulate, might be jeopardize the third line like darunavir, which we have been preserving, twice daily. So this is something what being shown from one of our very earlier work, maybe 15 years back or 16 years back we published. At that time, we never had viral load monitoring. We had only CD4 monitoring. The patients who have got a failed who are immunologically, we had stored specimens using a research grant in NIH. We did genotyping. At that time, viral load monitoring was not a routine care. In certain centers they were doing, it was very expensive. So at that time, what we found in that is people who have been failed immunologically, they have a lot of mutations. Again, not a new data, old data. They have a lot of CAMs, and as well as 25% of patients had more than 3 or more NNRT mutations. So that means if you're not doing viral load monitoring, you're going to do a lot of harm to the patient, not only immediately, but also for the future where some of the drugs are, under preserved. Because of this, we lost a very important drug which had saved millions of lives across the globe, both nevirapine and efavirenz, which now you know that the resistance mutations have gone beyond 10%, most of the lower and middle income countries, in India up to 10%, and because of this reason, now it is out of this guidance. And this again happened, I will call one of the culprit was we delayed introducing viral load monitoring in resource limited setting. If you would have done earlier, probably would not have accumulated so much such mutations. Again, having said this, now we have moved forward with a new line of therapy, not new anymore, it's a preferred therapy. And efavirenz is out of basket. It will not be even not anymore even alternative when you see the next guidelines. Now you're going to see this. whether this king coli we call dolutegravir will be continued to be a king coli in future. So this is a meta-analysis of various published clinical trials where they use dolutegravir as a preferred therapy antiretroviral naive patients. What they've seen in that is, various trials like Spring, Flamingo, Single, and Advance. And if you see this drug also can fail. So if you see this column, the last one column, where you can see this, anything from 2 to 5% of the patient can fail viremically. But when they did a resistance mutations, almost zero. I have shown similar slides many years back to the same audience here, where using nevirapine and efavirenz, where when we did a resistance mutation, it could be anything from 15 to 20% of them will have NRT mutations, or even up to 40%. But with the dolutegravir, when someone starting therapy who are naive, who are never exposed to any antiretroviral drugs, starting things in these clinical trials, we have shown zero mutations, but even if they have failed virology. Again, having said this, what will happen to the other drugs which we have been using on this? As we all know that someone who fails efavirenz containing nevirapine, we change them to AZT containing therapy. The current WHO guidelines also recommends when someone is on tenofovir, you speculate what will be the possible mutation and change to the other NRT AZT. But I know that you're not going to do that, you're going to recycle this drug. Again, why we earlier recommended this recommendation of changing from tenofovir to AZTs based on this large study which is conducted across the globe, and including sites here in Chennai as well as in Thailand, where we contributed data to a large global database of patients who have been failing tenofovir containing therapy with K65 mutations. If you see this multiple chart, just look at the one from our region of Asia, where in our region, in India as well as in Thailand, when they fail with tenofovir, 39% of the patients can have K65 mutation and they fail virologically. In sub-Saharan Africa, almost around 50% of them have these mutations to tenofovir. For these reasons, we recommended at that time change from tenofovir to AZT. We all know that it's such a toxic drug. But what we found in that is, accidentally, in this particular trial, again, we published 12 years back, a trial called second-line study, patients who are failing NRT-containing therapy. We switched them to 2 different regimens, one without NRTI using at that time with lopinavir and dolutegravir, and another arm, either we recycled the same NRTI or switched without doing genotyping. So what we found in that is, if we use NRTI, whether they had any mutations or not, almost the same as compared if you're not using NRT. So it gave us some idea, hey, this NRTI, even if they have mutation, can work in future if you recycle. At that time, we didn't know that when we published this, but we gave some caveats when we published in this Lancet manuscript. So this principle was used now to develop another clinical trial, which is already been published in Sub-Saharan Africa, called NADIA study. The researchers here, what they did is patients who are failing in NRT-containing therapy, which is NACO, called TLE. So what they did is they randomized into 2 different groups. One group received dolutegravir, another one group darunavir 800 for second line. And also it's got another randomization. What they did was, one group they changed to the WHO guidelines of changing to tenofovir to AZT. Another group they recycled the same tenofovir despite they had mutations. And also with the darunavir arm, you also had a randomization. One group received tenofovir recycling, another group AZT and 3DC. I'm not going into the details of the entire metrics of the study, but just for this talk on resistance, what they found in that is this K65 mutation doesn't matter, in terms of virological success. What they found in that is even if the K65 mutation is absent, they are superior as compared to AZT. And also, even if they have tenofovir mutation to K65R and they did not have AZT mutations, then again the patients who are on tenofovir, who are recycled, who have got a almost comparable or higher virological suppression as compared to AZT. So this study very clearly sees that this NRT mutation, particularly with the tenofovir, didn't matter anything to this. So initially, they said the study was done in Modern Africa, a small, different set of populations. Then we backed up with another study called DEP study, which was done across the globe in India, Chennai, Thailand, many sites in Africa, Latin America, and many other, even in Mexico. So what we did again in this similar trial is like a NADIA, patients who have been failed a NADIA containing mutation. We randomized into 3 different regimens. One, we recycled tenofovir from TLE to TLD, and 2 other arms, one arm to tenofovir, 30C, and darunavir, another one, newer regimen of ritonavir, darunavir. 48 weeks data have been published. 96-week data, we presented at the Munich conference, and now it's just published, got accepted at Lancet HIV. What I like to show in that is, so this bar chart is patients who have been switched to WHO recommended 2 NRTIs and a PI. We use a protease inhibitor feature of 70% virological suppression. We use a newer regimen with the dolutegravir darunavir, which has got a higher virological suppression, and we recycled tenofovir, despite the had mutation, we had a higher virological suppression than this. Again, this study very clearly backs NADIA study where you may even need to recycle. Now, using that particular results from DEF study, so I had gone into the WHO guideline. What you will see in future, probably in 6 months' time, is the recommendation will be you can recycle from TLE to TLD, which you have already been doing because of these 2 studies, NADIA and DEF study. And also, we have got such a robust regimen of darunavir 800, once daily, and dolutegravir could be a very superior if we cannot use tenofovir because they have renal toxicity or some of those bone or some other toxicities related to tenofovir. Also, we recommended that currently the adesinavir or lopinavir have more toxicities in our region, where darunavir 800 could be a comparable one, and also can replace even atesinavir containing therapy. Also, we gave, using these studies recommendation, if you have been using TLD, that's your preferred therapy now, when they fail, again, you can use either one of those PIs, preferably a darunavir 800, because our DEF study have now shown evidence that this will be a better drug as compared to adesinavir and lopinavir. Again, now whether this dolutegravir, which I kept saying that it's been working very well, is like a Virat Kohli, whether it's continuing to be a King Kohli, we do not know. So again, this is a lot meta-analysis on all those patients who have been switched to dolutegravir containing therapy from a previous resistance mutation, either to NNRTA, or they have been viremic with some regimens like TLD. Without doing a viral load, you change to TLD, or in a patient who are already failed. So a meta-analysis was being done on those patients. In that, they found they continue to see virological failure, but in this, they started accumulating dolutegravir mutations. So this is alarming. In the innate patient, we did not see any mutation, but they are already exposed. They are not been exposed to dolutegravir, but they are already been viremic with some regimen. If you are switched in a hurry, without doing a viral load, without seeing the optimized background, then cause a damage to them. And also, if you are using monotherapy, there are some trials that have been done, shown that it can develop a lot of mutations. Now, the next 3-4 slides will be a very busy slides, which have been published very recently on dolutegravir resistance mutation. So this is again a study which has been published from Botswana on 100 patients from a large cohort who have been viremic, and out of those, 83% were on dolutegravir-based therapy. And among them, 30% have very low-level viremia, that is less than 1,000 copies, but more than 20, and 70% had a definition of virological failure of more than 1,000 copies. They did genotyping on 58 of these 100 participants, and they found that 33% of the people in the low-level viremia, they had any mutation, despite they have been backed by such a wonderful drug, dolutegravir. And 32% had mutations in the virological group. Again, this very clearly shows that even if they have low-level viremia, before our virological failure mutation, they can start developing resistance, even if they have dolutegravir along with it. But again, this study very clearly shows that not dolutegravir resistance, hey, if you got a low-level viremia, you're not doing something, improving adherence or something else, you may even lose dolutegravir, this particular study said. This is another very large scoping review, which was done for a WHO guidelines of 43 different clinical trials where they used dolutegravir either for along with the 2 NRTIs or with a PI or with a monotherapy or various things. They all put together on quite a lot, 2,131 patients, and they found in that. But these are all from clinical trials. What they've seen in that is dolutegravir-based regimen fails, but they fail. The resistance mutations are very less. But these are all clinical trials. You know that how we do clinical trials, there will be a lot of support and very clean populations, and they are very closely monitored with viral loads, so on and so forth. Still can fail, but with a low level of resistance mutation. But on the other hand, what you're going to see in the real life data, it's been published from the center from Africa, on a large 15,000 odd patients, where 157 patients who had virological failure with and dolutegravir containing therapy. Out of those, 85% had been successfully genotyped. What they have seen in that is 9.4% of them had developed dolutegravir resistance. This is something for the first time they started showing dolutegravir can develop a resistance. And they concluded saying that 9% of the people with persistent recurrent viremia, I'm using the word recurrent viremia, after changing the dolutegravir therapy can develop a resistance. We all did really from TLE to TLD during the COVID time, the whole programs and everything, saying that this will be a big eye opener to follow that particular cohort. Following this, WHO is going to be a warning now, stating that dolutegravir can develop a resistance mutation, particularly in the population. You switched on viremic while on failing therapy, or without knowing their viral load. To understand this, now we are doing a large global survey with the support from US and NACO. Hopefully we will continue to do that without, Trump has not harmed our study yet. So it's still ongoing, across the globe. So what we are doing is DTG versus study is anyone who is failing, doctor conducting therapy, either first line or already second line or third line, or switched while doing highly viremia in globally till last week. We enrolled 1,000 participants globally, not in Chennai alone. Chennai is one other site, but we have sites in Africa, Latin America, and throughout the globe. It's been supported by NIH. Again, after the first time I'm going to release the data, never been published. I showed few of these, a couple of months back in Bangkok, but now I'm showing a little more extended data showing that we have already seen dolutegravir resistance. Now this is a real-life data, not from the clinical trial data. What we are seeing that is patients who have been failed and we have done sequencing and we have seen is almost around 23% of them can develop a mutation to dolutegravir. So again, among those, we are seeing E138 is the most common one, followed by 118 and as well as 66A. And also the signature mutations like E140K, we saw that, and as well as N125X. So that means dolutegravir resistant mutation have entered research limited setting. Keep a watch on this. So how we are going to prevent this, right? And again, we can't keep on talking about new drugs and all those. How we can prevent this? One such strategy is, with the long-acting injectables. You heard from Jürgen yesterday. It's a beautiful lecture. It's been approved by US FDA called CAPRISA, and can we use this in our patients? Again, a very nice study. Again, he showed yesterday in San Francisco on patients who have been viremic, who don't want to adhere to the medication. What they did is, Monica Khan is a researcher who went and gave injections in the community on those people. So what they did is, they excluded patients who got NNRT mutations in that particular study. They found that good virological suppression of almost around 55 of the 57 patients had virologically suppressed. And they continue to see this suppression over a period of time even after a year. But again, these are the patients who did not have NNRT mutations. But in a situation like in India or in lower and middle income country with NNRT mutation, can this drug work? Dr. Glory showed earlier briefly on this case study which was done in adults. So again, it was done in Uganda, in Kenya, in South Africa. What they found is that they did not do a genotyping, but they collected and stored the samples. They found that equal virological suppression between cabotegravir and rilpivirine in these patients. But they found in that anything around 13% of the patients who had NNRT mutations still this drug works. Can we use this in our things? We need a little more implementation science studies before we scale up in our region. Again, we have other drugs, newer drugs like NACO, you heard yesterday, for prevention as well as for treatment. Now it has been approved for use, which can be given subcutaneously, which will work both in naive patients as well as in patients who are already experienced. Again, it is every 6 months, but we need to have another good partner because cabotegravir is only 2 months. Rilpivirine, we do not know whether we use it or not because of the NNRT mutation. Unless we have a good partner along with that, then this drug might be very difficult. Again, another new drug under development, again, it's been published by Jürgen, who might be in the audience here. A couple of years back now, this drug development is going on using the drug called Latravir, which is a translocation inhibitor, can work against the K6PR mutation as well as against AZT mutation, and a BACRIT mutation, and 3D mutation, which was paired with another new second generation NNRT called Doravirine. What they've shown in that is, it has been comparable as compared to TAF-FTC bictegravir. And again, they have done some dose ranging studies and they have found a dose of 100 milligrams of Doravirine and 0.75 Latravir, and they keep developing. This might be another new option for everyday oral therapy in our patient, particularly if they are resistant mutations to dolutegravir and as well as to NNRT to the first generation. Then what about these other oral? This is again, you heard a little bit from from yesterday's speakers. Drug called Latravir and Lenacapavir as once daily, every 10 days. Sorry, not once daily, one tablet, every 10 days have shown comparable suppression as compared to everyday oral therapy. So this is something important because we have generic manufacturers here who can do anything. So these are 2 tablets. They have to swallow, every week or every 10 days, which they can do, and they also can compare as a single pill. And this again become 2 classes of drugs, not integrase, not PI, and not NNRT and no NRT. So that even if they have mutations, still it can work. We need to wait for other advanced data. And also there are a lot of new studies going on. Yesterday you heard on neutralizing antibodies. I don't want to bore you with this. This is something which look for it. Maybe another 2 years down the line, this became part of our treatment guidelines. So today, as a clinician, don't sit tightly with your TLD forever. So look for these long-acting and newer drugs. You have to use appropriately. You have to preserve dog-driven mutations. If we can use these much before they develop that, then we can protect that particular class of drugs. Again, dog-driven, which I said has started developing resistance mutations. Whether the long-acting drugs will do that, again, this is a very nice review just published very recently on 33 studies where they used long-acting cabotegravir and rilpivirine, and they have seen virological prevalence of 1% in detection studies and 1% in switch suppress studies and 5% in switch viremic studies. Again, they have done some resistance mutations, and what they have shown in that is, again, the viremic is very less if you use this long-acting injectable, but if they fail with severe resistance mutations, so that means even long-acting cabotegravir rilpivirine will not be a king coli, which can cause mutations. So you have to be very careful again, when you use these drugs in your settings. So again, before I'm going to end my talk stating that as a private doctors, many of us are using this two-drug regimen, which is a wonderful drug called 3DC and DTG to protect against the kidneys and as well as in the bones. This is something, please use it in those patients, especially who are suppressed viral load. But the day when you use it, keep repeat the viral load after 2 to 3 months, because if they develop a mutations, then again our doctor class will be gone. This is something what I want to show this because we are all using this in our region. Don't use in hepatitis B mono-infected as well as in TB patients because we don't have any good data in that. I like to conclude my talk stating that HIV persists throughout the body despite all this antiviral therapy. Preventing resistance will be our future quest. We cannot keep talking about newer drugs. We've got good drugs, how we can prevent resistance. For this, we need long-acting, not just long-acting, high genetic barrier, combination antiviral. We have the NACO every 6 months, but we don't have a good partner, cabotegravir every 2 months. Now they're developing every 4 months. So can you ask a patient for 4 months to do one injection, 6 months one infection? These are some of the things we will go through that, but we will fix it. There are researchers been working on that, where we need to have a good answer on this. Again, I like to end my talk, thanking some of my collaborators for some of the studies which I've shown, and also, some of them shared some, good slides to me. Again, thank you for this opportunity. Happy to take questions at the end. Thanks.
Thank you, Dr. Swami. Any question will be in the last after one session. So now next speaker is Dr. Hubli sir. So the impact of drug resistance that Kumar Swami elaborated, but how to interpret drug
ASICON welcomes Dr. Gunisha Pasricha. Dr. Gunisha Pasricha is Associate Director of Research Services and Infectious Diseases at Major Labs, Pune. Dr. Pasricha has over 15 years of experience in industrial and academic settings, specializing in molecular microbiology. She is skilled in developing and validating methods for identifying and genotyping microorganisms as well as heterologous protein expression. She has successfully delivered a biocatalysis technology for a leading steroid manufacturing company in India. Dr. Pasricha has published 21 papers in national and international peer-reviewed journals demonstrating her commitment to research. We look forward in hearing her talk on interpretation of drug resistance testing.
Thank you for the introduction and good morning everyone. Thank you organizers and special thanks to Dr. Kumar Swami for having invited me for this particular session and for giving me the opportunity to talk about drug resistance. So I am not a medical doctor, I'm a molecular microbiologist and a PhD, so apologies for any mistakes from the fraternity of all medical doctors here. So what are the drivers of HIV drug resistance? Not going into all the drivers here, I will just concentrate on the virus, being a molecular microbiologist here. So I'll just concentrate on the HIV subtype, its replication capacities and genetic mutations, which drive drug resistance. So as we all know, the subtype C is prone to more drug resistance and it's the one which is more prevalent in India. And also the replication capacity and mutation rate of HIV makes it worse for HIV since their replication rate is 10 rounds per day. It has an RT enzyme which is error prone, so it adds on to the mutations, like 3 into the 10th power mutations per base pair per cycle, which causes lot of genetic recombinations.
Because of this, there are various different HIV-1 viruses. Different sequences infect the same cell, making it genetically distinct variants. That's what quasi-species is called, and that's how all resistance also evolves. So I'll not talk about all the HIV drug targets and resistance. Most commonly used targets are, as Dr. Kumaraswamy also mentioned, RT protease and integrase, and I'm just going to talk about those. I'm straight away going to dive into what HIV drug resistance and how it is tested. Probably it might be new, or probably many of you are already using this technique. So I'll talk about genotyping, proviral DNA-based genotyping assay, and phenotyping. So when it comes to genotyping, it is basically directly sequence of HIV genome is sequenced to detect mutations. This can be done using Sanger sequencing and next generation sequencing. I will also introduce the audience to what next generation sequencing is, because I come from a genomics lab. So basically we do direct sequencing of protein coding regions of RT, TR and integrase, find out the mutations, match the mutations against the mutation database, and do the interpretation, which is very, very important, because the effect of mutation is cumulative here. Now, for the proviral DNA-based genotypic assay, it is again a next-generation sequencing-based assay where the proviral DNA is sequenced, however, that is non-replicating. ART regimens failed. Usually, a viral load is currently indetectable. So, probably this particular genotyping method is mainly used for detecting archive mutations. And however, these archive mutations are not understood so well, and hence it is not a popular method of genotyping. The phenotyping, you can it is analogous to the antibiotic susceptibility test, which we do for bacteria. It measures the HIV replication in the presence of drug. However, it utilizes a recombinant virus system, which makes it very complex, and it becomes also very expensive. The summary of this is genotyping is good. Method is the best method to do drug resistant testing. So just taking audience through what sequencing types have been. There is the first generation sequencing, which is the Sanger sequencing based. The second generation sequencing is the next generation sequencing based. And the second generation is the short read chemistry, and the Illumina sequences are into that space. And the third generation sequences are the long read with the PacBio and ONT. So I mentioned that genotyping is done by Sanger sequencing, or it is done by next generation sequencing, and I thought I could just mention that here. So what is next generation sequencing? It's nothing but, it is massive parallel sequencing technology that offers high throughput sequencing, which has great scalability and speed, and determines order of basically nucleotides of the entire genomes or in particular targets. So NGS has actually revolutionized the biological sciences and allows labs to perform wide variety of applications. So what does it have? It basically has 4 steps. You extract DNA, it's written DNA, but in case of HIV, you extract the RNA, chop the RNA, convert it into cDNA obviously, and chop it up and add some targets to it so that the sequencing can be done, what is called library preparation, and then sequencing, and then analysis of all those sequencing data. Seems simple, but there are complex steps to it also. So there is a misconception that next generation sequencing is extremely expensive. As you can see in this slide, from 2001 to 2020, this is the cost of human genome sequencing cost, which is more than 100 billion, and it has fallen off to like $1,000, and as of 2025 it has fallen further. So there's a misconception genotyping can be done by NGS-based method. So this particular slide just compares what Sanger sequencing and next generation sequencing is. That the next generation sequencing obviously has an advantage because it can detect simultaneously sequence of thousands of individual genomes, and it can detect mutations at far lower copy numbers. It can detect variation up to 3% threshold. What I mean by 3% threshold is if in a mix of viral pool from a particular patient, if the virus or mutation is present at only 3% of all the HIV strain can still detect. Now, while this does not happen when we do using Sanger sequencing, where the threshold is 20%. So only dominant mutations can be detected by Sanger sequencing.
by next generation sequencing, you can also detect those minority variants. As what I see, that minority variant studying is very, very important when it comes to, because it can increase the risk of biological failures or impair immune recovery and lead to accumulation of drug resistance. However, for genotyping, we need a viral load. Has to be done before we do genotyping, and the copy number should be at least 500 to 1,000 copies of this virus. HIV1 should be present. So conclusion of this particular, the next generation sequencing is a better technology because we want to detect lower thresholds, we want to detect the minority variants which are also there. This workflow of what next generation sequencing I've already mentioned, so I'll just rush through this. So what I'll do is just mention what drug resistant interpretation. Now, it is challenging, the interpretation, especially because there are many drug resistant mutations occur in complex patterns, and drug resistance have diverse effect in each drug class. Now, unless you are using a database which already has done this homework for you, then things become easy. Especially if you're doing interpretation using Stanford database, which I'm referring to here, there are more, but this is the most popular and the most well used by WHO and all other many agencies. So this is nothing but contains a freely publicly genotypic resistant interpretation system and can be accessed via HTML or automated web service. So basically it has integrated workflows which has been adopted, I said, from WHO and HIV Drug Resistance Network, NIH funded clinical studies and trial groups, and several hundred research and clinical laboratories have worked together and brought this Stanford database into place. So when you are interpreting any drug resistant database, it is important to include mutations from all previous resistant tests as well, because the mutations, as I mentioned earlier, are cumulative. So how does an interpretation go about? Especially when you have done the sequencing using next generation sequencing or Sanger sequencing base, the sequences available, and that particular sequences are fed into these databases, and what it does, first it does is it lists out all the mutations which are present for RT, BR and integrase. It generates drug resistance score for each drug, which is 0 to 9 is susceptible, 10 to 14 is potential low level resistance, 15 to 29 is low level resistance and intermediate, and then it's a high level resistance where the drug is ineffective. And then it gives drugs wise susceptibility information, and then gives a recommendation of what drug regimen could be used. Just a few more terminologies which I wanted to introduce, that it is non-determined means there is an incomplete sequence coverage across the gene or genes, and susceptible, as you all know, and potential low level resistance, that there is presence of drug resistant mutations that suggest prior ARV exposure or associated with resistance only when occurs alongside with other DRMs, while low level resistance is presence of DRMs that are associated with reduced in vitro ARV susceptibility or a suboptimal biological response to ARV. And an intermediate resistance is nothing but it indicates that there is a likelihood of reduced ARV activity due to the virus DRMs, and the ARV is still expected to retain a significant antiviral activity. And higher level is obviously when the DRM is predicted to confer a level of resistance similar to seen in viruses. Not going into the details. So this is just dummy results of what I mentioned, the various 4 steps which the results come out. So this is for HIV RT mutations, reverse transcriptase mutations. You can see these are the mutations of the nucleotide position. It gives you all the mutations. It gives you various thresholds. As I mentioned, your NGS can go as low as 3%. So this particularly tells you that this particular mutation, in this particular case, it is not a dominant but present in 3%, also gives you prevalence of what drug resistance in the literature is, and gives the susceptibility score. Like I mentioned before you, there are various susceptibility score, and here as you can see here, the susceptibility score is approximately 40%, which it means it is an intermediate susceptibility to all these drugs. It gives drug-wise report, like drug resistance or susceptible, intermediate. This is for the NART drugs and this is for the NNRT drugs. And it gives you all, in this case, this NART was completely susceptible, so that's good news. It gives us a recommendation of drugs which could be given. So the first is A1, as you can see in the first column there, A1, which basically tells that it is a strong recommendation. There is something in the scripts at the bottom actually, which A means strong, B means moderate, and C is optional. So basically this is strong recommendation that this particular recommendation by the database will be a good treatment to go ahead. And when it comes to the Roman number 1, which is there, which says that one or more randomized trials have been done, and these are the outcomes, and it has been validated. And if suppose there was a 3 here, but here it's all 1, then there is expert opinion because of which this drugs could be used. It also gives a combination regimen which can use. This is again a Stanford database which I'm referring to. And these is nothing but scores which are called the genotypic susceptibility scores, what is called GSS. So here in this case, if you see it is 2 by 3, which means that 2 drugs are active, but one may have resistance. And this regimen is still functional but could be potent. So this kind of guidelines is given for clinicians to help decide what drug regimen could be used. So the benefits, so basically I'm summarizing. So NGS is highly sensitive, it can detect low frequency DRMs before clinical treatment failures occurs. This serves an early warning system, allowing healthcare workers to providers to adjust their ART regimen and proactively prevent the spread of drug resistance. It also gives a complete view of the viral population, identifying both major as well as minor resistant mutations. A comprehensive profile helps in customizing ART strategies based on specific drug resistance pattern of an individual patient. So a patient-centric treatment can be given. Obviously, surveillance is always there, and NGS helps, routine HIV drug resistance at population level, helps track mutations, trends, shaping public health policies, and it is crucial for adapting national treatment guidelines and optimizing resource allocation for HIV care. No, also, what is important when the genotyping happens, when the NGS happens, we also do subtyping. So subtyping also becomes very, very important because some subtypes, as I mentioned to you earlier, subtype C is more prone to drug resistance, which has faster disease progression, while others may have a lower resistance. It helps in detecting drug resistant mutations, which are more easily make it critical to tailor ART regimens, epidemiology, and also it helps in defining or designing various vaccine designs, and as Dr. Kumar Swami was mentioning, that broadly neutralizing antibody strategies also, which might be the future for the coming years. There are challenges obviously into all of this because NGS is costly and infrastructure deploys, there's a costly affair to all of this. There's a bioinformatic infrastructure is also involved. Analysis platform require payment for subscriptions, and interpretation require robust databases. And these databases also have to be updated regularly, and standardized guidelines have to be followed and reviewed again and again, for especially when you are having interpretations. So I come from Medigenome. It's a genomics company which is based in Bangalore. Not going too much of what we are doing. We are India's market leaders for genomics. We have a testing portfolio across reproductive genomics, pathology, rare inherited genomics, cancer genomics, and obviously infectious disease genomics, which I represent, and we also have research multiomics. Apart from genomics, the world is moving towards proteomics and metabolomics is something which, and I also represent the research, I lead the research team there as well. So these are the platforms for you to know what these NGS platforms look like, just a glimpse. So Medigenome offers these tests, NGS-based tests. We use Stanford databases We do testings for all these genes and also, whole genome based. I suppose we're just into research and want to look at what is happening in these particular genes, but also look at the whole genome coverage and what are the potential or novel mutations or which could be responsible in future. That can also be done, and obviously subtyping is something we can do. These are all the drugs which are covered in particular tests which we offer. And I just wanted to end, I think I have 3 more minutes, just to the audience that microbial genomics is powered by NGS, and there's a lot been happening, especially when it comes to One Health kind of scenarios where the drug resistance is completely rampant all across antimicrobial outbreak infection. You look at monitoring and surveillance in healthcare, and in all of this, I think the routine microbiology tests are moving towards more about microbial genomics. Is something which I just wanted to mention to all of you. As I mentioned, AMR is a silent pandemic, and I've been closely working on HIV and other antimicrobial resistance, where we do whole genome sequencing of bacteria and viruses and work on it. And similarly, I think, I don't want to mention, but I wanted to mention, if you talk about HIV and not talk about TB is something, and I've been also working TB and drug-resistant tests for some time at MedGenome. So when you see this is the global, this is the WHO report of 2024, which I just wanted to mention, where India figures in all the 3 lists, TB, HIV, MDR, RRTB, and TB. India is right there. So I know we are working all towards it, but yes, more needs to be done. There is a particular test, NGS-based test, which we offer, which we are passionate about because we developed it ourselves. This particular drug-resistant test can be done directly from sputum or any other clinical specimen. It could be an extrapulmonary, done studies in sputum and also on CSFs. So this particular, it's just that you need to have a diagnosis already, have a gene expert positive, and once you need to do drug resistance, this is a culture-free technology, and you could just sequence the whole genome and find out the drug-resistant targets. WHO has already released a second catalog of mutations which is associated with drug resistance that has come as of November 2023, and within 14 days it's rapid, because otherwise you have to wait for the culture to grow, and it could be 6 to 8 weeks by the time it grows, and this is like a 14 days and you actually understand what drug resistance is. So it gives you drug resistance reports for all the first line, second line drugs, other drugs which are not in the WHO regimen, and also rifampicin. I just heard somebody talking about it, so that's covered too. So hope for the future is the recent WHO approval for NGS-based testing for TB directly from clinical samples marks a significant step towards integrating next generation sequencing into mainstream infectious diagnostic. And probably this milestone could pave the way for it, also NGS adoption for HIV drug-resistant testing, offering faster and more comprehensive drug-resistant profiling. And with this expanded, especially after COVID-19, there have been a lot of RT-PCR and a lot of sequencers which has popped up everywhere in India, and I'm hoping, this will make things easier in the transition to HIV drug resistance much better in future. Yeah, thank you.
Thank you for making the talk simple and comprehensive. The session is open for the questions and comments for all the speakers.
Wonderful talk. I know at MedGenomes many things are going on, but I wanted to ask, what is the time duration when we can get a drug resistance routine report and NGS? Means if a sample is drawn from my clinic, there are logistic, I know.
Yeah, just 1 week. Yeah. It can be given 1 week. That's the time.
1 week. Okay. But do you do the sample every day, or you have got a specific date? Means every day. If I send from my place, I can get a report in 1 week. Okay, and the viral load should be more than 1000 per NGS, whereas other drug resistance, what you mentioned, is at least minimum how much you want? 1000 copies.
Because we do not offer single sequencing. We offer more of NGS-based services. So 1000 copies is the minimum which you require.
Last question, cost. cost of?
Probably about it later. I'm not from the sales, but there is somebody outside probably. I'll connect.
Yeah, I know there are beautiful network and logistic. People draw sample and right from a clinic or any clinic. I really congratulate your team. I'm happy with it.
He means if there is a discount or discount to
I'm sure. There is Suryakan who's somewhere outside who's from the sales, probably I can connect.
Just a quick one, Isha. Use in STIs. Are you using the new technology for identification of STIs, sexually transmitted infections?
We have a multiplex PCR.
Right.
We have a panel.
Right.
Which is started like a day where there are 8 to 10 organisms which are covered in that, and that is offered.
That could include syphilis.
Yes, I have to check. I'll get back to you.
Okay. Thank you very much.
Yes. RT-PCR is something which you offer, especially the lab.
Very informative lecture. I have some basic thing in reference to HIV molecular analysis. When we grow the virus or a patient where the virus is growing, the progeny will never be pure. There will be a combination of mutated and non-mutated viruses. So for testing, how to take care of this part? You never get a pure virus form. Even if you cultivate it artificially, you will get a mixture of the mutated and non-mutated. So when we want a purification, what step we can take?
Basically, what you're saying is you want purified drug-resistant HIV? No? Purified virus.
Once progenies are there, progeny will be a different correct. And we want to concentrate on one particular one.
But what this particular test does is, at that particular moment, we collect class 1, we do not culture it. Directly RNA is extracted. So at that particular moment, when you've drawn the blood, so those viruses which are present, which are replicated, representation of the replication which is happening in the sample is represented here. So we do not grow the virus.
All are not the same genetic constitution.
Correct. So that is why both, there will be a mixture of viruses. You're absolutely right. It will be true, but it will tell you what percentage of those viruses are there and what prevalence is there and what threshold this particular mutation is.
Any specific technique for separation of this mutated and non-mutated?
This you can make out by NGS. This particular test
Only
will
by
for
this.
various thresholds.
Proportional we can do.
Yes.
Thank you.
I'm not too sure, probably Dr. Kumar is coming. I'm not too sure.
So the National AIDS Control Organization actually has a program that has started. So there will be 2 labs, one in NIMHANS and one in AIMS Delhi, that will do resistance testing for network, the public health network. They are using an NGS platform.
This is not new. NACO is already having regional thing. But again, the question is whether they're going to do NGS or cytosequencing. I think the current ones, what they're already doing, they have one in Chennai, in NART, as well as in NARIPUNA. It's already been done even for the earlier things. Now they are expanding. So it's a question of money, to get a NGS sequencer, I do not know the cost, probably you can ask her. And it's so expensive. And you need so much of expertise and manage. Unless you have a huge volume sample, you'll not be able to break it. I think our programs can have it, but it's the cost. And one other question, gentleman, beautifully asked is, now here, the one Dr. Manisha was talking about is all genotyping. So the one, similar like our antibacterial culture, is what is called phenotyping. Now, phenotyping is not done in India or in any other research university because it's very expensive. It's done only for research purposes in the US and in UK, or I don't know even in UK, but lab in Europe does that. So that's very expensive, very laborsome. So, but on the other hand, there are validation studies have been done between phenotyping and genotyping by the Stanford group. And based on data correlation, we have developed this Stanford database. And the Stanford database will have sequences from different places, even from India also. We have uploaded a lot of sequences from subtype C, subtype B, D. So based on that, so they have a formula, say that probably if they see this mutation, these are the drugs. It will be like almost around 90 to 95% correct. But only if you do a phenotyping, 100% will be correct, same like that. Yeah. So that's a.
Hello. In multiplex PCR, we have been doing the bundles, and they are predefined organisms in group. Whereas we don't get a resistance patterns in multiplex PCR. NGS, are we getting the resistance patterns like KPCs, SBLs, MOX? Are we going to get that?
Right. So I think talking about regular tests, like we offer something for sepsis, where it has 20-25 organism, also has drug resistance, major drug resistance genes are also covered. So RT-PCR also can cover certain drugs. So however, we cannot cover all of them. So RT-PCR has that. Yes, NGS-based drug resistance testing is actually, we've been using this very actively, especially for NTMs. Because there are no drugs, phenotypic drug susceptibility tests which are there, and there are no guidelines much. So what we use is a CARD database. CARD database is a very good database which is freely available, which is curated well, and this is all for drug resistant testing for all the clinically important drug resistant bacteria which are there. So we use that particular CARD database to tell you the indicator. Again, this is all research, where we have seen many of the doctors have been using this and find these reports very, very useful. So yes, to answer your question, yes, that's the future, but research as of now.
But you are not giving it in your multiplex panels?
Multiplex panels, yeah, only for sepsis.
Only for sepsis?
For sepsis, yes.
Not for the PU?
Yeah, it's qualitative.
So far they have not given the resistance pattern. But NGS maybe, yes?
NGS, yes. But we are actually developing a test, NGS-based test for drug-resistant testing also. Again, it requires many years of validations to bring it out. So that's what we are doing. Thank you.
Okay, any questions? Other questions? So there's no question, then we close the session. And thank you so much for the attending.